Okay, good evening, everyone, and welcome to the second in our paediatric series. Thank you for joining us this evening over on Middle. It is my absolute pleasure to introduce this evening Dr. Helen Armstrong, who is a paediatric consultant in neurodisability. She joined us last week for our safeguarding talk, and this week will be teaching us all about mental health in paediatrics and how to approach it as a junior doctor. So over to you, Dr. Armstrong.
Thank you, James. So we're going to be talking about mental health in paediatrics. So just a little bit about me. I've been a paediatric consultant at Calderdale and Huddersfield Foundation Trust for the last 4 years. I'm the designated medical officer for Calderdale and Kirklees for SEND. I teach on GIC, APLS and NLS. I've been an instructor on the Yorkshire and Humber STEP programme, which is the specialist education in paediatrics programme, for longer than I've been a consultant. I used to be the trustee and holiday leader of a children's charity where we took away disabled children. I am the purveyor of fine reptiles. I really shouldn't type things when it's late, but my dream reptile is one of these beautiful chameleons that you can kind of see lower in the screen, which I held in a shop. However, they are divas. You need to mist them twice a day, so I haven't got one yet. I do, however, have 4 snakes and a gecko. I am a Tough Mudder enthusiast. I say enthusiast. I'm enthusiastic for the first mile and less enthusiastic by mile 10. I absolutely love a good gig. I've got some tattoos, and I've recently, in the last year, become a surfer and skateboarder. So, you know, I try and be down with the kids, but let's be honest, I am not so down with the kids as I would love to be. So let's crack on. So what we're gonna say, this is just a little bit about our sponsors who are helping keep Mind the Bleep as good a service for you guys as it can be. So what to expect from our session? So I'm going to talk to you a little bit about the size of the problem. Then we're going to talk a little bit about some common presentations, a little bit about what you want to be thinking about in your history. Quickly going over what you already know about the mini mental state exam. Talk a little bit about management. Talk about my favourite problems, the problems of social care and the problems of CAMS. Go through a few cases. Have a Q&A, which James is going to hopefully find any questions for me. And then talk a little bit about some useful resources. So
yeah, sorry to interrupt. If anyone does have any questions, just stick them on the Facebook event and I will pass them over to Dr. Armstrong at the end. Okay.
Fab. So essentially, as we all know, lockdown and COVID have been pretty rubbish for everybody, and child mental health was a problem before that. However, what we are seeing now is daily admissions for self-harm, be that coming through A&E, through GPs, or just directly to the paediatric assessment unit. That doesn't always mean they need to stay in, but they all need some form of mental health assessment. Sorry. We are seeing a double to quadruple level in admissions for children with eating disorders. And this includes younger children. So it used to be predominantly a problem of teenage young ladies. However, we are seeing children down to the ages of 8, and we are seeing an increased prevalence in boys. That doesn't mean that we're not seeing the cases in girls. We absolutely are. But sadly, it just means it's expanding in all regions. We also see, sadly, a breakdown in placements for fostered and adopted children. Essentially, whenever anything gets tricky in life, it gets most tricky for those who are already really vulnerable. And sometimes, sadly, you'll see these children, for want of a better word, being dumped on the ward until social care can help us sort out that situation, which is really pretty sad for all concerned. There's an increased presentation to clinic with more outpatient presentations of mental health, such as headache and non-specific abdominal pain. And also, we're seeing at least a doubling of school absenteeism. Now the scale of which will vary from child to child, but school absenteeism is just a really early sign that something might not be quite right. So as I said, we need to be talking about it, which is one of the reasons why this is a session that we're doing as part of this series. And just to give you some facts and figures, essentially the HSCIC in 2004 said 10% of children aged 5 to 16 had a clinically diagnosed mental health disorder, 6% had a conduct disorder, 4% had an emotional disorder, 2% had a hyperkinetic disorder, so you think of things like ADHD, and less than 1% had things such as autism, tics, or eating disorders. However, that 1%, let's be honest, has rocketed. Autism is about 4-5%, and eating disorders is probably a similar number. So we're going to rock through some common presentations. Now, let's be honest, I apologise for my terrible sore throat. We're going to do this one at a time. And I am not a woman that makes lots of PowerPoint slides. So we're going to do a lot of talking around it. So if while we're going through, you've got a specific question about that element that we're going through at the time, just pop it over on Facebook and James will pass it on over to me. So we're going to start with the heavy hitters. We're going to start with self-harm. Let's be honest, if you're a medical school student, I'm sure you've seen some on your placement. If you're a junior doctor, I can guarantee that you have seen someone that has self-harmed. It is the most common presentation that we see acutely. Now, usually this will be cutting. It's the most common thing. But sometimes it can be bruising, burning, pulling out hair, pulling off nails. Sadly, there's a whole range. The most common we see is cutting, and it's thankfully usually fairly superficial. Usually these young people will present through an A&E department, so it's really common that you guys are going to be the first people that see them. And the key things for you to do is think to yourself a couple of things. Number one, how bad is it? Obviously, is it deep? Is it fairly superficial? Because if it's fairly superficial, you can probably clean it up, find out exactly what the trigger was, if they can even tell you, because sometimes they won't be able to. And think to yourself, what level of mental health intervention is required here? Because the answer is always some, but the amount will vary. So if a young person is self-harmed, it's fairly superficial. They're with a carer that's a decent human being, and by that I mean they're going to actually keep an eye on them over the next 24 hours. And you speak to your psychiatric liaison team or the CAMS liaison team, and you have a bit of a chat with them, and they often have, at least in Calderdale, they have a chat with the family over the phone. And if they say they're okay to go, that may be sufficient. So it may not take any longer than your standard A&E clerking and intervention, but yet you still have that extra little layer of kind of mental health glittering on it, for want of a better word. So your psychiatric liaison team are always an excellent point of call. Sadly, sometimes it is deeper, and I have seen young people that have required assessment by plastic surgeons for either because and it's usually accidental, let's be honest, they've accidentally cut a nerve, or they've accidentally gone much deeper than they intended, because the blade or whatever instrument they're using is sharper than they thought it was going to be. And when we come onto the cases, I will take you through a case when I was a registrar that we'll pick out as we go through that case the interesting things that can happen, perhaps some red flags, and perhaps some top tips on how not to get yourself in a tricky situation. Let's move on to intentional overdose. That's probably the other most common presentation you're going to see on an assessment unit in paediatrics. Let's be honest, the most common hitter is paracetamol, but that can sometimes be combined with salicylates, plus minus alcohol, plus minus diazepam, plus minus whatever they can get their hands on. So cocodamol is another thing that often you'll see. Obviously, your key questions are how many, when, over what time frame. Because if it's staggered, you're going to be thinking to yourself, I want to get out my Parvalex protocol pretty quick. Well, your N-acetylcysteine Parvalex protocol. You want to be thinking about, are we 4 hours down the line from when we took these medications? Can I take the bloods yet? in A&E, which is real helpful for us on the ward, or do I need to refer them up to paediatrics and give them the time at which those bloods will need to be taken? Because let's be honest, as a paediatrician on a busy unit, it's really helpful if you guys on the front line, or even if you are clerking for me on the paediatric unit, say to me, oh, Helen, this child will need bloods, but they're not due until 9 p.m. And even if that's not on your shift, that means that can go up on the board so that we all know that when that time hits, they can be taken off so that as quick as possible, we're going to have an answer about whether that child needs to stay in or have extra medication. So these children in intentional overdoses always need a cooling off period. I don't believe there's a CAM service in the country that will just happily let them go home. So they usually end up staying overnight, regardless of what time they've come in during the day, and regardless of whether they are medically fit. So that's the other question you want to ask yourself. Are they medically fit for home? And by that, I mean, is their paracetamol level less than the normogram? If you've had to give them an acetylcysteine, you are following your current local guidelines. I say that because we did have a wonderful national guideline that essentially ran a bag over 4 hours, ran a bag over an hour, then over 4 hours, then over 16 hours. And it's changed recently. There's a wonderful new normogram that runs it much shorter. And both the gastroenterology colleagues that I have in Leeds and across the country, and also those within A&E have kind of worked together to sort out a new protocol that only takes about 12 hours and isn't seen to have any negative effects on liver function or on your clotting factors. So please, I would urge you just to check what your local department is doing. They may be on the old protocol, they may be on the new one. Let's be honest, we're all kind of slowly shifting. And as we all know within the NHS, these things change to variable rates. So the key thing for your overdoses, whatever your protocol is, when you get to near the end of your protocol, so don't wait till the end of your protocol, don't wait till the end of bag 16 or bag 12, whichever it is, and about an hour before, take your bloods then. Because let's be honest, a clotting and your LFTs, they're going to take at least an hour to come back. And if you haven't got that result, you're going to be writing up another bag. And that's going to be annoying for you. Oh, but it's going to be even more annoying for your nursing colleagues who will look at you like you weren't prepared. So 1 to 2 hours before, plan to take those bloods, because then you're going to have that result back ready for when that bag ends. And you can say to yourself, what's my INR? Because let's be honest, that's your top hitter. And then you look at your LFTs. And if your INR is okay, your LFTs are okay, then you're pretty safe to stop that medication. It's at that point you are medically fit. And only when you are medically fit will most CAMS teams come and assess that patient. Sadly, depending on how good a mood / how busy your CAMS colleagues are, will depend on whether they will accept a phone call to guesstimate the time at which someone will be medically fit, and then a follow-up call when they're ready, or whether they won't even take any details from you until that child's medically fit. And sadly, that will vary from region to region and from colleague to colleague on an individual day. But those are just little nuggets to be aware of for when you're thinking about your intentional overdoses. It's also worth thinking about, sometimes they'll be weird and wonderful. If the presentation you see is odd, and we'll come on to that again in one of the cases, just have a think to yourself, could there be some other medication or drugs of abuse involved? Think to yourself whether you want to do a urinary tox screen, and just think about kind of perhaps adding in an extra question or two that might cover that in your history. But we'll go through that when we come to the cases. So moving on to eating disorders, I'm sad to say that it is becoming more and more part of my daily life. Let's be honest, when I became a consultant 4 years ago, I maybe saw one every 6 months. Now I'm seeing 1 to 2 children as an inpatient on my ward a week. And they are long-term patients, because sadly the ones that hit the ward are the ones that our wonderful community CAMS team have not managed to keep in the community. So these will be the children that's BMIs are horrendous. These are the children that will look skeletal. These are the children that really need tier 4 CAMS beds that do not have access to them because of either capacity within the country or capacity within the local system, or worse still, capacity within social care. So you as a local paediatric team are kind of thrown into the deep end of looking after these patients, and it is tricky. So first of all, acknowledging that yourself and your nursing colleagues, your senior clinician colleagues, will find these cases difficult because they are not our bread and butter and they are not our pièce de résistance of knowledge. You know, show us all a bronchiolytic, boom, sorted. Show us a child with anorexia, we all panic. Because although there's some great marzipan guidelines, so for those of you who are making little notes, marzipan, absolutely wonderful guidelines that you work from. However, even with the wonderful marzipan guidelines, you and I are not paediatric dietitians. And typically, these cases do not come in on a Monday or a Tuesday during working hours. They come in on a Friday afternoon at 4 p.m. and you'll be clerking them at 5 p.m. and you'll be making a diet plan at 6, 7 p.m. and you'll be thinking, why am I making a diet plan? I'm not a dietitian. And you'll be thinking to yourself, how many calories are required in a day? I don't really know. And you'll be having little questions to yourself about, do I need to do refeeding bloods? And the answer for the ones that come in is almost certainly yes. And we'll go through a case study where we work through these issues. But those are the things I want you to be thinking about, because they're, in reality, the things that everyone finds tough. My top tips are always be on the same page with your colleagues. And by that I mean make a consistent plan. Put it in your notes. We use EPR up in Calderdale. I make sure that if I make a plan for a young person with an eating disorder, it is stamped like a red mark across the notes in massive letters, so that when my colleagues come the next day, they do the same thing. Because the thing that children with mental health disorders, particularly eating disorders, find trickiest on the ward is a lack of consistency. And I know this from wonderful and terrifying feedback from actual patients. Because the worst thing for someone that is essentially controlling their life by controlling their food, because it's the only thing they feel they can control, isn't helped at all by a system that is caring but changes its mind. Now, of course, we all know that there's some flexibility, and we all know that there are things that change that we can't control. But for the things we can control, such as how much they need to eat in a day, if you know that that young person is going to have a breakfast and then pick a piece of fruit for snack, don't change that plan unless you've got a dietitian that's come in and changed it for you. And then you go in and you update that young person on what that change is so that you're all on the same page. The best thing I did for my last CAMS patient was laminate her a copy of her diet plan and put it on the wall in her room, so that every day, not only did I remember, not only did she remember, but the wonderful junior doctors doing the ward round could see it at a glance. So if they weren't sure, they had an eyeball view of it as they walked in. And because I am a visual learner, it was color coded. So every different point was a different color. So that way also your eye gets drawn to those different points as opposed to like a sea of black. My other top tip for those with eating disorders is they want to exercise all the time. And even when you've got someone that has great insight, and the young lady I looked after most recently had great insight, she described it as, I don't think I can get over the voices telling me to exercise. I don't think I can fight against them hard enough to not exercise. So you need to think of things they can do instead. Things that can occupy their time, because to be honest, it is rough being in hospital when you are well, when I say well, kind of with a physical disorder. It is even worse when you're unwell with a mental health disorder, especially in COVID, where you can't really leave your room and wander the grounds and wander the ward. So you're essentially trapped in a cell for a week, 2 weeks, a month, and it's horrendous. You need to think of how you're going to make that better for that young person. And let's be honest, my top tip is ask them, because things aren't going to work the same for every child. This young lady loved colouring, so I printed out some colouring for her to do. And I said to her, if you colour this for me, I'll put it on my wall in my office. And so I printed out colouring that I liked. So I now have a steampunk owl on my office wall that this young lady coloured for me. And when I'd go in the morning, if she hadn't finished it, she would show me what stage she was up to, and we discuss the interesting colour palette she'd used. And so not only does it give you something to act as a method of rapport and ice breaking at the start of your ward round, it gives them an excellent distraction. But that will be different for everybody. She also liked playing. She had some not odd games, but like she had some games I hadn't seen, board games. And she also liked puzzles. So she'd unfurl this massive puzzle across the whole table she had in her room. And then when I wanted to examine her, she'd roll it up. or push the table out of the way when the zillion-piece puzzle wasn't required. So just ask. It's a great rule of thumb for almost everything in medicine, but it's particularly a good rule of thumb if you're thinking of activities to help a young person. School absenteeism.
So I could just go back with the children that you're working with eating disorders. Do you get a reasonable amount of compliance with your diet plans and kind of your distractions and new kind of activities?
So the honest answer is variable. So this young lady who had great insight, on her good days, she would smash her diet plan. She would be absolutely distractible, but yet she would still have a screaming fit for about an hour before breakfast, because she knew breakfast was coming. She knew that it involved calories, even though we were picking the low fat options. I remember for this young lady, I had the carbs and cals book for the diabetics, trying to help her pick from the hospital menu the lowest fat options that gave her the calorie content the dietitians recommended per day, to help her pick food that would fit the calorie requirement we needed, but would be within her sphere of acceptability. The other extreme is young people who completely are not with you. Now, then you're in a tricky situation of, are the parents with you or not? If the parents are with you, that's the kind of situation you're in where you're thinking about nasogastric tube feeding, however challenging that is. And you sometimes use the bridled nasogastric tubes, which can be very challenging for the child and for staff. We had a young lady that, again, would scream and kick off at the nurses every time that NG tube was accessed. And that would be approximately 3-4 times a day, which is awful for that young person. It's awful for the nurses. And so it's really important to think about, because of course we put in loads of support for the family, really need to think about looking after ourselves and looking after each other as a team. And even if that's just at the end of the day or during the day, a quick check-in going, are you all right? I know that's a tricky patient. Is there anything I can do to make it better? And the answer might be no, but it might be that person just needs a quick hug. And sometimes that makes life a whole lot better. Sometimes it might be, do you know what? Do you mind just coming in with me to do this next feed change? And the work of 5 minutes for you as a junior doctor will make the life of that nurse a million times better. So variable is the answer, and on a case-to-case basis.
Okay, thank you. Yeah, no, really, really helpful.
School absenteeism. I think this is probably the most tricky thing I face, because it can be really difficult to get to the bottom of it being a mental health disorder. So school absenteeism will not always be a mental health disorder, is number one. But let's be honest, it's at the top of my list of reasons why most children are absent from school, other than the ones that are deliberately playing truant, etc., etc. And some of the ones deliberately playing truant maybe your young people that have ADHD may have autism but be very high functioning and really struggle to interact within those lessons. So it's still worth having it on your differential list. If you see a child, so this is more likely to be in a community placement or in a GP practice, or for those medical students, when you are out with community nursing colleagues, or school nursing colleagues, or even if you have relatives, friends that are teachers and they say to you, oh, I've got this kid that's never in my class. And maybe it's worth saying to them gently, have you ever thought about why? And it might be that your wonderful teaching colleague has really thought about why. They are on it like a car bonnet, and it is just a really tough situation. But it might be that child is presented with constipation, that they are off school for weeks at a time with manageable constipation, and in reality, they hate school. And be that because they're being bullied, be that because their IQ is not that at the level which they find standard learning pathways straightforward. It's worth thinking about. And my top tip in those scenarios, because let's be honest, school absenteeism tends to present as an outpatient problem rather than an acute problem. Have a chat with the school welfare officer is usually the best person. But in my experience, I've also interacted with head teachers, pastoral workers, and have a little MDT, have a little school MDT, have a discussion with those people, get it from both sides, because let's be honest, school are going to have a lot of information that you don't have, and you're going to have a lot of medical detail you can feed back that they won't know. And then between you can come to a plan. The best thing to do is have a little discussion, and you know, in the world of Teams and Zoom, have a little Zoom meeting with those people first, and then add the parents and the child in. And hopefully what you want to do is bring them along for the ride, so that you as the medical professional suggest that their medical problem may have an element of somatization or functional issues. And that doesn't mean that their constipation isn't real, because let's be honest, it is. They're just not managing it very well because of everything else that's going on. Or they are having unrealistic expectations, such as nobody needs a sick note when they have constipation for weeks on end, and nobody needs to be admitted to the ward just because they are screaming because they won't take their Movicol. I say this because I have looked after such a patient and she was very challenging. And during lockdown, I heard not one peep from her. She had 0 admissions. She had 0 challenges with schooling because she was being homeschooled. And funnily enough, she went down to 1 sachet of Movicol. In the last month, I have had 5 emails from her school teacher because she has not been at school for anything other than 1 week. Apparently, her constipation is getting worse again. And her GP is giving her a sick note to be off school for her constipation, which I have suggested might need a professional conversation about the nature of the problem. So that's one of my ongoing cases at the moment. School absenteeism, tricky business. Constipation is not the only thing, as we'll go on to talk about. There are lots of medical presentations that have a flavour of mental health that is worth thinking about, because when you're in your clinic, if you only deal with the physical side, you are not going to treat that child. They will keep coming back to your clinic until you address the other side. And so sometimes a 2-prong approach is required. Sometimes a single-prong approach that looks like a 2-prong approach is required, but we'll come on to that. Is there anything else anyone wanted to ask about school absenteeism, James? Perfect.
No, nothing's coming through at the moment.
Perfect. So I'm going to take the next group as a bit of a batch, because the themes are the same. And I know that most of you can take a reasonable headache history. I know that most of you can take a reasonable palpitation and collapse history and a reasonable abdominal pain history. And what the theme is here is somatization and mental health with a physical presentation. So essentially, they will present to clinic in the way that anyone else with a headache or abdominal pain will. And your job, as usual, is to be chief detective and figure out what the trigger factors are associated with that case. And so typically in a headache history, you might be listening and thinking, this child sounds pretty anxious about life, not just about their headache. And if anxiety is a factor, that's always going to make headache worse. Because if they're anxious about their headache, they're anxious about that it could be a brain tumor. They're anxious because their family member died of a brain tumor. They're anxious they're going to die. And if you don't address, even if it's not at a CAMS level, mental health element to that, you are going to fundamentally miss treating half of that child's problem. Because giving them some pizotifen or some, my mind has gone blank for all the drugs I use, propranolol, to manage their headache or their migraine, isn't going to make an ounce of difference if you don't control their anxiety associated with it or explore their anxiety around it. Now, for different children, that might be in different forms, because for some young people, cognitive behavioral therapy, great. For some, just talking about their worries with a parent, carer, trusted friend, you as a doctor, might be enough. For some, they might need some medication, because if they are so anxious, you need to bring that down a notch so that they can even clear their head enough to start processing. Which is why, for those children, propranolol, mint drug, you not only help with the headache, but you also help with the anxiety. That low dose propranolol, kind of 10 to 20 milligrams, depending on the size of the child, obviously, is an absolute gem for helping a two-prong approach. Of course, you need to be thinking about all your other hard hitters, such as, do they have asthma? Don't give them beta blockers. And are they on any other medications? But just think out of the box a little bit when it comes to those presentations. I would say exactly the same about non-specific abdominal pain. Non-specific abdominal pain is the most common outpatient presentation in pediatrics because it has so many different causes. You have your constipations, you've got your recurrent UTIs, you've got your safeguarding, you've got your mental health difficulties, you've got your somatization, you've got your bullying, you've got your genuine irritable bowel or your inflammatory bowel diseases. And you as the doctor need to pull that apart. That's what makes pediatrics really interesting. You need to think to yourself, what are those key things that are going to tell me whether it's one or the other? And what are those factors from my history that are going to point me in that direction? And what I'd say with things like non-specific abdominal pain is think to yourself, what key investigations do you need to do to tell yourself it's not any of the big hitters like ulcerative colitis or Crohn's? So, a nice little stool calprotectin is going to take you a long way. And maybe you want to test their thyroid, especially if they're quite thin and very anxious. And maybe you do a celiac screen. But after you've done those three, you don't really need to do a massive full blood count unless they look pale as a pale thing. You don't really need to check their LFTs unless they look yellow. Because the key thing is working hard and smart, not doing every test under the sun. You're going to do better for your patient, you're going to do better for the NHS, and you're going to be the kind of doctor that I want to work with. So once you've got to the fact that there is a mental health element, you then need to package that to address that with the young person. And depending on how old they are, depends on how you go about doing that. For a very young person, a kind of 4 or 5-year-old, I often say something like, do you know what? When I feel really rubbish or a bit anxious, my tummy feels like it's got butterflies. And sometimes that means my tummy really hurts, and it hurts as bad as when I'm poorly. And that is a real pain, but it's because my brain is poorly and I don't feel very happy. It's not because my tummy is really poorly. So how about we think about a way to make your brain feel a bit better? And then I think your tummy will feel a bit better. For an older child, and let's be honest, you're going to gauge this upon response and the interaction, that's not a real word, interaction you've had with that child so far, because you might be able to have a very in-depth conversation with an 8-year-old, or you may have to have a very low-level conversation with a 12, 13-year-old. That's all going to depend on their learning ability, on the interaction and insight you've had from them so far to guide that. Because you might be able to have a conversation that goes, look, we both know that sometimes we can't fully explain how we're feeling. And sometimes those feelings get expressed in physical symptoms. And we need to address those physical symptoms that are being brought on by things that we find difficult to talk about. So you tell me whether you think talking to someone from, say, CAMS is going to give you a hand, whether you think actually just coming and talking to me is going to be enough, whether you think we need some medicine to take the edge off the pain while we work through these things, or whether actually you think, do you know what? I know what's going on now here, Dr. Armstrong. You give me the resources to go and look after it myself, and I will. And we'll check in on each other in about 2-3 months. And that is the essence of collaborative care. Now, of course, you need a certain level of good interaction with a child to be able to have that level of discussion. And as I said, that will depend on the ability of the child. But working somewhere from the telling the child what's going on, all the way up to having that really lovely collaborative discussion about how you're going to manage it is the spectrum that you want to be thinking along. If you're dealing with a younger child, of course, you're going to have a pretty in-depth conversation with the parent as well. Tell the child what's going on. I always do my best to speak more to a child in clinic than the parent, even when the parent does that beautiful thing of looking at the child that looks really anxious and going, do you want me to tell the doctor the story? And they're like, and then it's absolutely fine to glean all the information from the parent. And I usually throw in a little line of, that's great. You can let mummy tell me the story, but if you think there's anything she's not told me or anything she's got wrong, you just jump in. And hopefully that gives a young person enough freedom that if there is something that their parents missed out, you've been open enough with them that they will add in those little nuggets, because those will probably be the gems that actually take you the longest distance towards what's going on. And those are the things that are going to build that trust and rapport so that that child opens up to you to really get to the nitty-gritty of what's going on for them. So I'd say the same go for palpitations and collapse. Of course, you need to be thinking about your cardiology things. So for those ones, always get an ECG, always check the blood pressure. Be thinking about if there's any red flags that make you think about the need for echo or 24-hour tapes. But also think to yourself, is that young person eating breakfast? Are they eating at all? Is there an eating disorder here? Is there bullying going on in school? Because let's be honest, I've had many a conversation with teenage girls that go along the lines of, I had a collapse after lunch. Well, after lunch break at school, I say to them, did you eat lunch? They said, I had an apple. And I said, that's not lunch, that's a snack. And they'll say, yes, but I get called fat at school and I feel pressured to look like all the other young people. And I look at Facebook or Instagram, Snapchat, and I don't look like them. And then I essentially go, look, I'm in the beautiful position that I'm a very short, curvy pediatrician. I can empathize with many people. And I often say to them, look, you need to realize that you are beautiful as you, but you need to think that, not just me. And so we need to get to a place where you're going to believe that and ignore the people that tell you otherwise. And there are some beautiful apps that can help you with that. And when we come to resources, I'm going to tell you about some of my favorites. Is there any questions about common presentations before we move on? Perfect. So history taking, let's be honest, time for you guys to do some thinking. I have, to be fair, put some helpful hints of psychiatric specific things on the left for you to look at a later date. I'm not going to go through them. I'm not going to insult your intelligence by reading to you. But if you think about all those key psychiatric things from your psychiatric placements or from medical school when you did your psychiatric block, you know, you want to be thinking about, how does that child look? How is that child speaking to me? What feeling am I getting about their mood and affect? What does their ideas and thoughts about the situation seem to be? Do they have any insight? And what is their level of cognition? Because all of those things are going to impact on how you investigate, how you manage, and where you take it. So what I want you to do is have just 2 minutes thinking about What are the key things you want from the history? Or better still, how are you going to kick off that history? You know, what nice open question are you going to use? What kind of questions are you going to use to gently take that history down the path where you do not very much talking and you let that patient take you through their story? So I'm going to give you 2 minutes. I'm going to let James kind of man the Facebook so that we can get a bit of feedback on that in a couple of minutes. And that gives me a chance to not speak for kind of 60 to 120 seconds while you guys do a bit of thought.
Yep, I'm having a look on the chat on Medal as well. So if people would rather post there, if that's easier, I think it's alongside the video. I can relay any comments. Let me just refresh. Okay, so the question is kind of, how are we going to open our history, and how are we going to try and get the young person or child to open up about their mental health, and get them to do most of the talking? Because someone in the chat has just asked to go over what exactly the question was again.
Perfect. That is exactly the question. So let me give you some top tips while you're thinking, just to kind of probe those ideas. Think to yourself, what nice phrases can you use to move a history along that doesn't involve you asking any extra questions, really? What kind of questions are going to be a good opener that's going to essentially let you delve into the heart of the problem without putting too narrow a band on what's going on? And then once you've got that bulk of that history, what key probing questions do you want to ask to really nail things down?
Okay, so we've got one person that's responded saying, can you tell me a bit about what has brought you here today?
Yeah, that's a nice question. I like that. That's a good one.
Yep, nice, open, broad.
Have we got any other bright ideas? Otherwise, I'm going to give you my list.
Okay. I always quite like to just tell me a bit about what's been going on with you recently.
I like that. That's a nice one.
Sometimes it goes wrong. I'm not going to lie. You can get you get a detailed what they had for breakfast, and then what they did in all their lessons in school, because they normally get interrogated by mum or dad when they come home. But for the most part, again, it's nice and open.
But even if you do get that, you can use that to your advantage. That's quite a nice icebreaker. And then you can say, oh, thank you so much for telling me that. Now tell me a little bit about why you're seeing me.
No, absolutely. I like that. That's very quick thinking.
That only comes from years of experience and of sometimes getting it wrong. And that's the beauty of these webinars, you know, sharing our life experiences and our top tips, because let's be honest, the STEP teaching program I teach on, I do challenging communication scenarios. And essentially we have actors that work with our ST1 and ST3 pediatricians. And every time I'll get little nuggets from those wonderful junior docs. I'll be like, that's a great phrase, I'm going to steal that. And I just add it to my armory. And in return, I'll share my nuggets.
That's a great way to learn. So someone else is saying that they often find the child's parent just shoots off and basically tells them everything. But then I think they're bringing it back to the point that you're saying, they try and acknowledge what the parents said. You know, you can't just ignore them. But they then say, okay, you know, let's address the child and say, you know, what's been happening lately, which I think is a really nice approach.
Or it might be that, so you're quite right, there are lots of parents that are so worried about their child that they essentially want to offload on you. And the most important thing to do is let them, because if you don't, that's going to be more of a hindrance to you when you get to the stage where you want to ask more probing questions. Because sometimes these wonderful anxious parents just are so glad that they're seeing a doctor that they just need to tell you everything in their life. And then you can go, okay, thanks for telling me all that. but how about you tell me specifically about this? And then you can start to direct them a little bit, because we've all been in those situations where you have a 15-minute sea of information where you don't really get those little nuggets that you really want to kind of dig down into the situation, but do give you a beautiful overview of what that family situation is. And do you give you a really nice idea of what that support network might be like for better or for worse? So as James said, really nice openers are things like, tell me why you've come to see me today. So in clinic, that's my favorite, because I often get GP letters that will tell me one thing and the patient thinks a completely different thing. Sometimes they think they're coming to see a paediatric surgeon, which I am not. So it's best to address, you know, we all talk about ideas, concerns, and expectations in medical school. And I think that you should not be by the stage when you are an actual doctor saying that out loud, but do be thinking it in your brain and thinking of a way that you can find out those things, because they are important to what you do. So I want to know why they think they're there, because then I can say, okay, that's great. So why I think you're here is this. My plan is to do X, Y, and Z. Is that okay? So for instance, a child that's come with headache. So their GP has told me they've got a headache. And I'll say to the young person or the parent, so tell me why you think you've come to see me today. And they'll say, oh, we've come to see you with headache, but we've also got 5 other problems. And that's a good point to say, okay, so your GP's referred you to me with headache. We've got time to talk about the headache today. If we have any extra time, we can touch on those other things. But think to me now, be having a think about what one of those other problems is the chief thing that's worrying you. Because then you're managing the expectation that you cannot cover 20 problems in a 20-minute slot. But what you can do is address the thing that's bothering them most. And that might not be the thing they've come to see you with, which is always a tricky business in medicine as a whole. Pediatrics, no different. Patients will come to see you with what you think is one thing and what they think is another. And it may all be the same thing. It may be that their leg that has just fallen off is a worse problem than their headache, which is now settled. And you may have the opportunity, if you have the skill set to do so, to address that problem and say, and write a nice letter to the GP going, well, patient X's leg had fallen off and that was distressing them, but we talked about how they could get a new leg. Their headache, however, is completely settled and I'm discharging them back to your care, etc., etc. Ways to move the conversation along. When you are talking about the bulk of the history, I find things like things that acknowledge that you're listening, but that you want to help them move forward are the key. So thank you for telling me that. I can imagine. So, and only be yourself is my other top tip. If you're not the kind of person that would be like, thank you for telling me that, I imagine that was a really awful situation. Can you tell me how that made you feel? If that's not you as a person, don't be that because I've told you to be that. You will find your way, and your way will be an equally good way because it will be unique to you, and therefore it will be much more genuine, and therefore the patient will respond much better. But that is one of my ways, and I have different ways depending on different patients. So the way I talk to my children with autism in my clinic is very different to the way I talk to young people who've come in with self-harm. So my children with autism, I usually say to things like, so how do you see this situation? You tell me what you think about it. And because the way they see the world is different to the way I see the world, let's be honest, I secretly love the way the autistic children see the world, or at least my high functioners, because sometimes I see the world that way but can't say it out loud. And they get to say it out loud and it's brilliant. And they want to talk to me about Star Wars and the fact that Darth Vader is amazing. And they'll jump up and down and flap and tell me all about how great Darth Vader is. But I need to occasionally tell them about sleep. Because sadly, when you're that excited about everything, sleep is sometimes tricky. But by letting them have 5 minutes to talk to you about Darth Vader, you can then have a 2-minute conversation about melatonin. So much like everything in life, it's all about trade-offs. And then other ways to move the conversation forward is things like, okay, so you told me that you were feeling really down recently. How long that's been going on for? So those little detailed questions that you acknowledge that you've heard what they've said and that you've listened and that you've got a follow-up question. The same with things like, so you tell me you've been cutting. How long have you been doing that for? What kind of things tend to trigger off episodes? How do you feel after you've done it? Do you actually feel better? And sometimes they'll say things like, I feel a release, and sometimes they'll say no. And then you can say things to them like, well, then we need to find you a better coping mechanism, because this obviously isn't working for you. And you've ended up in hospital for the second, third, fourth time. Let's together find a better way. Because the thing that upsets me most about children's mental health is the way professionals deal with it. And I have seen a zillion professionals be beautiful, have some lovely conversations. I've seen junior doctors do a better consult than I could do with a certain child. But I've also seen, the worst conversations ever, where essentially people have not acknowledged that that young person has feelings, that they see them as a case, as in this is X and they've self-harmed. And because they've self-harmed, they've done it to themselves. Why am I bothering? They're taking up my time when there are children with diabetes that need me. These children need you just as much. And your care and empathy will take you so far with these young people. There is a reason why I accidentally get pet patients, or have patients that I worry about for a long time on the ward. And please don't be me. Don't get highly involved with every case, but also don't have a heart of stone. I cannot imagine most of you on here do. Most people who are interested in paediatrics are wonderful, warm-hearted, giving people that just want to make child's life better. But we all have days when we have been on a 12-hour shift and we are knackered and we just want to go home. And then a challenging clerking like this comes in and you feel emotionally drained, so you aren't emotionally ready to have the best version of this conversation you could. And it is just worth us being emotionally intelligent to recognize that within ourselves. And so it might be that you take a perfunctory history. So you get the key details, you get the key information, but that you think to yourself, either myself or a colleague needs to go back later and have a proper interactive talk with this young person, one that's actually going to be able to move forward our management plan. Does that make sense? Perfect. Enough about history taking. A brief word about the mini mental state assessment. I don't do them all the time in paediatrics. You know, there's some advantages and disadvantages that I'm not going to read through to you, that you can look at when you watch the video back, or just, you know, as I mumble onwards, you can read them on the slide. But if when you meet a young person, you are struck by the fact that their GCS does not appear to be 15, ask yourself these questions and then potentially ask them these questions. Because if you've got a young person that for whatever reason isn't able to interact with you on an appropriate level, you may not be able to get that level of discussion about mental health that you want to today, but you might need to address their alcoholism or their use of marijuana or other drugs that have weird names that I always think, oh, that's a new one. You know, when you call drugs things like Smurf and stupid things that I don't understand, I will go, I'll ask Talkspace. And Talkspace will tell me what to do. Talkspace is your friend, my friends, for all things. And, you know, there's always someone lovely in the poison service that you can phone up and go, as again, we'll talk about, we'll come to the case of, where I go, this child's 13, their GCS is 12. Why? We think they've taken, bum. How do I make that better? Or what do I need to do to monitor them until their GCS is bigger? And so there'll be occasional children I'll do this for. And let's be honest, I sometimes do this for young people that present to me with additional needs or SEND concerns, because it gives me a really quick idea of roughly where they're at. And you don't necessarily need to do the whole thing, because you're not necessarily using it for the exact same reason you would on, say, an adult with dementia. But it's giving you a nice idea about if a child can't remember 3 objects, then there is some memory difficulty. If a child doesn't have the attention to be able to count down backwards, that might point you in one direction, whereas if they have flight of ideas, pressured speech, can't name objects for you, then to be honest, childhood strokes happen. And they may well be a differential for a child that presents with what looks like a mental health difficulty. And actually, when you kneel down to it, they've got a really subtle right-sided facial weakness, and the power in their hand is 4+, not 5, and you probably need to scan them. So these are all things that are going to point you in a direction. So my other top tip in life, as we discussed last week in safeguarding, was try not to tunnel vision. I know we all do it. But try and think to yourself, hang on, let's look at all the horses, but be aware for that zebra. Because once in a blue moon, there will be a zebra. And if you've got all your ears pinned back and your eyes and your radar wide, you won't miss that zebra when it comes along. Management. My top tip is mental health is not going to be fixed by you as a clinician alone. Mental health is personal, and it is something that you only really take hold of when you as a patient take hold of it. And I can say that as someone who suffered with a bout of anxiety a year into becoming a consultant, because being a consultant is hard. And so some of the apps at the end I've used myself and are brilliant and really make a difference. And so I am well aware that you need to be ready to fix yourself before anyone else is going to be able to fix it. But there are things that you can do to encourage them to talk, encourage them to stay in contact with friends and their support network, encourage listening between family, encourage routine, encourage thinking well of themselves and others. Because let's be honest, who's our biggest critic? Ourselves. We all know that, because let's be honest, medics out there, we're all slight perfectionists, most of us. And we all think to ourselves, oh, we only got 70% on that test. Everyone else got 80%. And then reality hits and you go, actually 70% is pretty amazing. And I passed, and this is medical school. I should probably be pretty proud of myself. And I'm not suggesting that you go to the polar opposite and become a narcissist, but I am suggesting that you're a little kinder to yourselves at times. And as I said, focus on controllable tasks. And it says hand washing. I think that can maybe be unhelpful for those with a tendency to OCD. But focus on things you can achieve. I would suggest that for any child you see with a mental health difficulty of any kind, suggest making goals, a little bit like you make a PDP. Things like, today, I want to make sure I do the washing up. That might be the only task they do that day. But if they have been in the hole of depression and they finally get to the stage where they can achieve a task and do it well, they should be proud of that. And you know what? You'll find over a week or 2 weeks, you can add on to that task list so that they're doing the washing up, they're picking out their own clothes, they're actually having a shower every day. And you are getting that child nearer and nearer to going back to school. Because let's be honest, little steps is the way forward. Those of us who think out there that you can suddenly go from being really poorly with a mental health disorder to being fine are misguided. What we really know is that it's positive little steps and acknowledging that for 2 steps forward, there might be 1 step back, but that's all right. And as I've seen across my Facebook pages recently, across my friends recently, acknowledging that it's okay to not be okay. And that talking about that is all right. And that actually, once you start to talk about it, you will realize that 50% of your consultant colleagues have also have a bout of anxiety at some point, because being a consultant is hard. And so that when you have a good rapport with your colleagues, and you can actually say to each other, you look like you're not having a good day today, you're right. And you then feel comfortable enough to go, no, I'm not okay. And they say to you, get off the ward for 10 minutes, go have a coffee. And you go and sit in your office for 10 minutes and have a coffee and a biscuit, and you feel a million times better and ready to go hit that ward again. As I said, being self-aware is really important. Having coping mechanisms and support networks is really important, because if you don't do it for you, how can you possibly encourage a young person to? So, as I said, confidentiality with safeguarding limits. So when you're talking to a young person, it might be that they're telling you some super private things. And that doesn't mean at a safeguarding level necessarily, but it might mean they're telling you the ins and outs of their relationships. It might mean that they're telling you about the really tough situation they have with a parent. It might be that they're disclosing things about domestic violence within the household, even if it's not aimed at you, not at them. So, as James wisely said last week, whenever you have a conversation, you say to them, look, this is all confidential, but if there's anything that makes me think that you're being hurt or that someone else is going to get hurt, I will have to tell someone. And most young people are pretty open to that. And so they know that you will keep what you can keep confidential. But then at the end, I would encourage you to also add on the caveat for mental health of, look, it's really important for our team to be able to look after you well, that most of us have an idea of what's going on. How much of this are you happy for me to share? So although in reality, you're going to write the majority of it down in your notes, what you can do is save a junior doctor face from going in and going, so on the notes, it says that you were going out with a 17-year-old boy and he touched you inappropriately. And that young person never wants to talk about that ever again. And you've already shut down that consultation by just walking in the room. Whereas if you know that that child has had a very awkward relationship that has got some safeguarding concerns, but they're being dealt with, what you can instead say to that person is, I know that you've been through a really rough time, and I know that you've had a really tough relationship. How are you doing today? And then you can work on with your ward round and your day-to-day tasks. You've not ruined any relationships and you've not broken any barriers. And you've not broken that child's trust. So it's all about the fine lines of when you can and when you can't. And if in doubt, always ask your seniors, always, or ask a colleague, because there will be a rich wealth of experience between you. Listen, I know it sounds simple, but let's be honest, sometimes we're not very good at it. We listen for what we want to hear. We listen for those trigger words like Melina and things like that. So for mental health, I want you to listen to much more subtle trigger words, such as when a child mentions that they haven't been doing the normal activities that they love. Or when you ask, is there anything they're looking forward to? And they say no. Or when you say, do you enjoy school? And they're like, silent will often be the case, just no answer. And that's the time at which to say, yeah, school is pretty tricky, isn't it? Tell me what's bothering you about school. Take any concern seriously. There will be some young people with mental health problems that will fabricate. We have to acknowledge that because it does happen. Or will not fabricate, but will be hallucinating. You know, my favourite young person, God bless them, was, and I can say this with jest because we caused it, is when you give them midazolam for a procedure to sedate them, and then they see spiders on the walls, or better still, that they act as if they're drunk and wobble down the corridor. Or on my favourite clerking from my ST3 placement in Airedale, when the child had got onto the counter and got hold of the open bottle of Lambrini and was genuinely drunk. A 3-year-old drunk It's the best thing you've ever seen, and the worst, because that is a safeguarding issue, obviously. But the tiny bit of you that can still find life hilarious after you've done the key things you need to do goes, that child was swaying like a drunk. Amazing. And they had to think to get a stool, to get up onto the counter, to get the open Lambrini, and then went, I'm going to drink the whole thing. Excessive medication is needed. Now, you don't need to be an expert in that as a junior doctor, so please don't think I'm saying to you, this child needs SSRIs. No, that is a senior decision. But it is really helpful if you've done an excellent clerking to go, this seems a bit more than the norm or a bit more than the average. I reckon specialist CAMS is going to be needed, and that actually some medicine might be needed, because then you can start to have that discussion with a child. You can say to them, look, I see that the level of your low mood is quite bad, and that actually talking alone might not be enough. Now I need to talk to my senior colleagues who deal with child and adolescent mental health, but it might be that they think some medicine's a good idea. And if that's the case, then I want you to know that we will walk through that process with you. As we said, excessive specialist CAMS is needed. Consider the mental health liaison team. That's more for when you're in A&E and you've got a situation where you think you can discharge and you need to have a discussion. Consider whether addiction or alcohol services are required, because let's be honest, however much we like to think that children don't need that stuff, teenagers are teenagers, and sadly, sometimes even younger than that. If you're in an awful situation, sometimes alcohol or drugs is the only way out for these young people, or they feel like it is. And I am not qualified to get them off alcohol. I am not qualified to help them not take marijuana every day, or wear still heroin, or, the hardcore drugs. But there are fantastic addiction services out there. And across the country, there are child and adolescent specific services if you need them. And you can always ask your adult colleagues for direction to those services if you don't know them. Or your CAMS colleagues. They often have kind of signposts for those too. Liaise with social care. Now, that's not always needed, but if you've got a looked after child, or you've got a child that's been in a safeguarding situation, be that they were found in the middle of the park on their own with a GCS of 3, as we will come to, or whether they were beaten up and you want to know, was that an adult, was that a child, was that a gang, you should involve social care. And most importantly, as we've said, give them resources for self-care. So the problem of social care, you can see that this slide is fairly blank, because essentially in my head, I think of this like a spider diagram. And when I was doing this slide, I didn't have the time or the mental resources to make a spider diagram. So what we're going to do is do a virtual spider diagram. So the problem of social care is several-fold. Had we more time, because I am aware that I talk for England, I would let you pull together some elements of the spider diagram. So while you're sitting at home, it may be that you think of things we can add on. So please do write on the whiteboard or write on Facebook ideas that you have about what might be issues with interacting with social care in this scenario. Because what I will do at the end of this session is I will make it into a spider diagram from the things that we talk about and any other ideas that you bring in. Because let's be honest, collaboration is the best way to work. So the chief things that are heavy hitters in my book is there ain't enough of them. So there isn't enough social carers, as in there is not enough social workers. They are time pressured, and they often don't have the specialist training required for very subspecific elements of mental health care. So lack of training, lack of resource, lack of physical humans, lack of appropriate beds, lack of time, lack of knowledge. The challenges of pulling together 4 or 5 humans in the same room at the same time, or the same Zoom at the same time. The problem of seniority. What you really want in a really complex case is a manager. What you get is someone that's just out of university. And do you know what it's okay to say as the medic? Can I please speak to your manager? But it's important to acknowledge that that lovely person you've spoken to is not a pleb. They are not someone that you can walk all over. They just don't know enough. And it's all right to go, thank you, you've been really helpful and really polite, but I know I need to speak to your manager about this, because I know that otherwise all you're going to do when we finish having this chat is phone them anyway. And I'd rather just skip a step. And even if that wonderful social worker is going to be managing that case after you've had that initial discussion with the manager, you've set them in a better stead where they don't feel out of their depth, where they don't feel uncomfortable, where they don't know the questions to ask you that are going to make a difference, whereas their manager will. So those are the main problems I can think of. I'm sure there are loads of others, which we will collaborate together at the end. So the problem of CAMS, let's be honest, similar spider diagram. The problem of CAMS. Number one, it's been eroded over time. It's been tier 1 CAMS has moved into schools, and school nurses are fantastic, but they are not CAMS practitioners. And so we are trusting, and not just trusting, because do you know what? I trust our school nurses. We are giving the responsibility and the onerousness of picking up low-level CAMS problems to our school nurses, who are already covering several schools and are overworked and underpaid, much like many people in the NHS. It is unfair, in my opinion, that we do that. Now, it is what happens, and sadly, it is a system that for the majority of the country kind of works, but we also know that lots of children slip through the net because of this, and because it is tricky to get into tier 2 or tier 3 CAMS, despite the fact that you can self-refer, and despite the fact that there is such a level of need out there. And that is one of the problems, the level of need. The level of need is high, and it is getting higher than it ever was pre-lockdown and pre-COVID. And we need to acknowledge that CAMS now very much take the worst of cases, and that actually as GPs, A&E staff and paediatricians, you're going to be seeing more and more tier 2 and tier 3 cases that you're going to be managing, whether you want to or not. You're going to be managing, and you're going to be taking advice from the CAMS professionals. So there are 2 or 3 cases that I run entirely myself, but will on occasion, when I come into a challenge or come into a bit of, I'm not really sure what to do here, we'll phone up our wonderful CAMS consultants or CAMS nurses and go, look, I need a bit of advice on this. What can I do next? And it'll be the work of 20, 30 minutes instead of the work of 4, 5, 10 hours for that CAMS practitioner if they were managing that child themselves. So we all within the service, a bit like that we need to get behind our GP colleagues when they're being bashed in the media. We also need to get behind our CAMS colleagues when, let's be honest, I have days where I'm like, CAMS, I hate you. All I want to do is refer this child to you, and all they need to do to get home is for you to come and see them. Why does it take you 12 hours? But we need to remember that individual CAMS practitioners are not there twiddling their thumbs going, I can't be asked to go and see this child with an overdose. And what they're actually trying to do is trying to manage so many children and trying to do the best for so many people that they can't be the best that they want to be. And they can't deliver the service that they'd ideally deliver in an ideal world. And we just need to be a bit mindful of that. And, you know, I say that to myself as much as to all of you, because as I said, there are days when in the heart of winter, when there's 40 children on the board and flow is awful. And as the consultant, you're in charge of discharging or doing ward rounds kind of 2-3 times a day to discharge, when you've got a CAMS patient that's been there for 4 weeks and you're thinking, come on, CAMS, pull your finger out. That we perhaps need to give ourselves 30 seconds and think, hang on, Helen, is there a reason why this might be? But we also need to be good advocates. If there has been a delay, we absolutely need to champion for the child that that's not all right. But we just need to do that in a kind and professional manner. So we, for our long-term patients in Calderdale, have a great system where the matron, the consultant, the CAMS consultant or nurse, and the named nurse for that child has an MDT, usually on Teams, once a day for our long-term patients. That means we can have a 5-minute, 10-minute check-in of where our progress is, so that A, we can feed that back to the family, and so that B, we all know what we're doing. Because if we don't talk to each other, that's where we all fall down. So those are the main problems with CAMHS. I'm sure there are others, like, guess what? We don't have a tick service. And you think, oh, but tics is definitely a CAMHS disorder. Though, let's be honest, our neurological colleagues are finding new and exciting ways of using drugs that I use for children with spasticity, for tics, that I am learning about every day and go, oh, you'd like me to use some trihexyphenidyl, or you'd like me to use some clonidine for these children. I feel a bit uncomfortable about that, but okay, let's walk through that process together and learn. And so sometimes in medicine, and to be honest, as you become more senior, you will realize that there is a little bit of hocus pocus that is based on fact. But the hocus pocus comes with going, okay, so we're moving into using this drug in a new field. We've seen some evidence that it might help, but for this patient, we're going to have to do a little bit of tweaking. Let's tweak with hand holding. And that might be you being handheld by another consultant that's done it before. That might be you holding the hand of another consultant because you've done it 3 times and they've never done it. And that is the beauty of having colleagues. My top tip in life, aside from just mental health in children, is when you decide for whatever area of medicine you settle in eventually, pick the place you work based on your colleagues, not on your speciality. Because the people around you that you have as your backup, or you have as your extra brains, because that's what I see some of my consultant colleagues as, my spare brains, will stand you in good stead. So I know that I am not good at cardiology. I can read an ECG, but if you give me a 24-hour tape, I look at it, smile at it, and read the summary on the front. And I can't really interrogate that data well. Whereas I will walk it down the corridor to my colleague Khalil, who is our cardiology lead, and I'll go, Khalil, can you just read through this and just make sure there's nothing I really need to worry about? And for him, it's a work of moments. He will do it in 2 minutes and be like, yeah, Helen, it's fine. But he will come to me having a child with cardiomyopathy and say, this child's really weak, Helen, and I've no idea why. I've done a CK and it's normal. Can you see them in your neurodisability clinic? And I'll be like, yep, that's fine. Because none of us are an island and none of us know everything. And the biggest revelation from when I went from being a registrar to being a consultant is consultants are very knowledgeable. That is true. But nobody knows everything. I genuinely think that especially as a junior doctor, I believed that consultants knew everything because they seemed to always be calm in a crisis, and they seem to always have an answer on a ward round. And some of that is because they've got years of experience. Some of that is because they've got a team of 10 to 15 colleagues behind them that when they go for a coffee break, they go, guys, I've got a really tough case on the ward. I'm really not sure what's going on. I've done X, Y, and Z. Can you think of what investigations to do next? And you'll have a 3 to 4 people level interaction where you'll make a new list together, and you'll come back to the ward and say to the junior doctors, okay, I'd like you to do X, Y, and Z test. And those poor junior doctors are like, how on earth do they think of that? And that's because 6 brains worked on it together. So there is some wonderful magic and jiggery pokery that happens behind the scenes that perhaps you don't always see all of at the moment as a junior, but that really does happen. Consultants are not infallible. Consultants are not all-knowing. They are experienced, but they absolutely, if they know what they're doing, share cases with colleagues, because you're going to get the best outcome for the patient that way. Sorry, I digress. So case studies. So none of these are written down because I want to walk you through them slowly. And again, I am terrible. I'm not terrible. I very much am the kind of person that when I'm teaching on GIC or APLS, I like to talk you through case studies and get you to shout back answers at me. Now, I know on a webinar, it's very difficult for you to shout back answers at me. So if you could shout back answers on Facebook, and I will just fill in the gaps where I would hear your voices for today, then that is what we will do. I'm only going to take you through 2 or 3 cases for the benefit of time. However, when you get to the feedback for this session or the question and answer, if there is a specific type of case that you are interested in or worried about, please ask, because I can think of a case for almost all the things that we've covered. So, case number 1, young lady of 13 presents with a 3-month history of weight loss. She used to be a dancer and a gymnast. She is now skeletal. She has been referred by the CAMS team for query anorexia nervosa, and her BMI is 16. You are the junior doctor on the admissions unit, and you need to clerk her, come up with an investigation plan and an initial management plan. I want you to just have 2 minutes to think about what those would be. So my top tips are: think about what key things you're going to be worried about. Think about what problems a severely low BMI gives you. Think about the problems that having not eaten for a long time gives you, and how you're going to check out whether any of those need managing acutely.
I guess as a current junior doctor, I can have a slight stab at this while we're getting some input. So with what we were previously talking about, start nice and open, so kind of what's been going on recently, explore any pressures that are at school or from dancing and gymnastics, both of which, at least historically, can have some pressures on kind of weight and size. Once kind of got a good history, thinking kind of investigations. At medical school, we always had to split it up into bedside, bloods, imaging,
Lovely, go ahead.
special tests. So at the bedside, we're going to start with, I think I'd want a blood glucose. Sorry, I'm also playing with my dog at the same time to stop her from whining. What else would I want to do? I would like a height and weight so I can, I mean, we've got a BMI. You've already told me that we've got one.
You still want to plot though, because you want to see
still, I want to have a look at it. Kind of also be looking at, as well as daily weights, kind of fluid and food intake outtake. Thinking about some bloods, definitely want to get U&Es, particularly if we're going to be changing this person's diet, thinking about refeeding syndrome and things like that. So as well as those U&Es, we're going to want a bone profile to look at the phosphate and calcium. Again, I think, let me have a quick look. Oh, I've got, someone is saying that they would do a celiac screen. That seems like something quite sensible.
Very wise.
We could do that. Yeah, that would be, yeah. And I think that highlights a really good point. We also need to be thinking about some of the organic causes. So yes, celiacs would definitely be one of them.
I'd add in some cheeky TFTs as well for that reason.
TFTs, yeah. Short synactin test. I don't know if you would get anorexia with Addison's, but...
So I'd probably not, so a short synactin, great idea, but it would probably be a second line test for me. You'd want to be looking at your sodiums and looking at your features on clinical examination before perhaps doing that test as an immediate.
No, that makes perfect sense. And I will finish with some sort of skeletal survey to see kind of bone density, depth. So that's more of an exam answer than I think a practical one.
So a DEXA, I can think of one child that I've done a DEXA on for eating disorders, and they had extremely severe demineralized bone on their bone age. So if your growth, so of course with things like anorexia, you often see very thin children, but hopefully you don't see very short children. If you see thin and short, then you want to be doing a wrist X-ray, traditionally left, to look for bone age, to see whether it's appropriate to their chronological age, because that's going to make you think about all your endocrinology tests. So be thinking about things like your hormone profiles, your testosterones, your prolactins, your 17-OHPs, and all the kind of things that I sometimes check with my endocrinology colleague for the full list, because there's always one I miss. And DHES, which I can never remember the full name of, but it's okay because you can find that test just based on that. So yes, do please be thinking about your potential organic causes, because they are the zebras that occasionally sneak in. And to trouble you. And my particular favourite on that account was a child I saw in Bradford. So it was a young lady who, of course, was wearing a hijab, who was very anxious, who was very tachycardic, who was very thin, whose BMI was perhaps 19 or so. So not terrible, but not good. And I came on for the night shift and was handed over by my day junior doctor colleague that I needed to decide what bloods were needed and finish the workup. Anyway, I went in and I was like, why is this kid so tachycardic? She's not septic. And I had a look at her neck and she had a massive goiter that had been hidden by her hijab. And I was like, I think we might need to do some TFTs on you, my friend. And funnily enough, that was the cause. And my colleagues were astounded, but this is not like I am a practical, simple person. I like simple things. That is why I'm a pediatrician. I like talking in simple words. I don't like long words, which is why I find orthopedic letters challenging to interpret at times, because I work in a world where I work with orthopedics a lot, and I sit in my clinic going, oh, is this equivarus or the other one? And I just want to say the foot is turning inwards because that is what I see. And that is what parents understand, because we use Latin when it's a beautiful language, but we don't need to use it to confuse our colleagues or our patients. So yes, but in this particular case, this young lady had come with a potential diagnosis of anorexia, and we did indeed do all of those tests except the short synaptin that have been mentioned, and they all came back as normal, other than her electrolytes, which were slightly out. She was massively dehydrated. Her urea was approximately 20 initially, and so for the first night we did actually need to fluid resuscitate her, not in terms of fluid boluses per se, but we did give her a litre or so over the first 24 hours of her stay with us, before we started giving her more food as well. And to add to your list is things like magnesium and zinc. So thinking about your trace elements that are really going to make a difference to potentially your membrane potentials. That, you know, magnesium is one of those things that I forget affects membrane potentials until it affects membrane potentials. And then you're like, oh gosh, magnesium. Yeah, I remember that it stabilizes the membrane. If you don't have enough, things go bad. And then say to yourself, what is the level of for want of a better word, cooperation that I have with this young person? Oh, my brain skipped a step. We all forgot that we always need to check blood pressure, and we always need to do an ECG on a child with anorexia, because they will often have arrhythmias secondary to their electrolyte abnormalities. So a baseline ECG and a baseline blood pressure is very helpful. Baseline blood pressure is helpful because, as I'm sure many of you will be aware, many of them have blood pressures in their boots, because they are either dehydrated or have been living off so little reserves that their body essentially goes into semi-shutdown and only does essential tasks. And so their systolic blood pressure may only be 90, which, depending on the age of the child, can be quite terrifying. And their heart rate may well be 40 normally. And so you will have to think about setting your alarm limits differently. Otherwise, nurses will be very distressed and will call your registrar multiple times overnight because their heart rate is 37. And they're like, they're asleep, aren't they? I'm like, yes. And their heart rate's only an average of 44 and they're awake. Yes. Don't worry about them then, unless they're blue or their oxygen saturations are abnormal. Just give them a little poke if you feel very worried. And then management for things like anorexia, as we said, look at the marzipan guidelines. They are fantastic. Try and get a specialist dietitian as soon as possible, ideally a CAMS specific dietitian, but in reality we know those take a week or so. So get your local dietitian as soon as possible. If you can't do that, make a sensible plan. And by that I mean, if while you're talking to someone you get a rough feel that they've been consuming about 200 calories a day, don't aim for what they need to be going for, which is like 1,500. Aim for something sensible like 500. And then you can build it up over a few days, because of course refeeding is a real thing. We need to be mindful of that. And also, that stomach's going to have shrunk down to the size of a peanut. And if you try and give it slightly more than peanut-sized amount of food, they're just going to vomit, and that's going to create an even worse cycle for them. So you need to introduce things slowly. So it may be that you give a high calorie concentrate, small volume for a few days until you can build up to more normal food. So it may be that you essentially say to them for a couple of days, you've got license to eat cake. I want you to eat cake and a small portion of cake, and that will be your food for the day. And then in 3 days' time, we'll work up to chicken. So that's case number one. Is there any burning questions that have arisen from that have come on to any? Brilliant. So case number 2, 11-year-old girl found unconscious in the park, GCS of 3, came in via A&E with a parent, was phoned by the A&E team to say, this child's GCS is 3, can we bring them up to the ward? And of course they went, no, nobody with a GCS of 3 should be on the ward immediately. So the registrar went down to assess them, confirmed that their GCS was not 3, but was in fact 9. Because of course, if your GCS is really 3, you're not protecting your airway and you probably need the anaesthetic team. Whereas if your GCS is 9, you're probably snoring and you may or may not need a Goodell airway, which is what this young lady did. And you're then sitting on the waiting game of, oh, when is this child going to wake up? And what test shall I do in the meantime? So that's my chief question to you. When you have a child who's been found unconscious in the park on their own with a GCS of somewhere between 3 and 9, who when you get to them on the ward, you put them in HDU because their GCS is 9, is maintaining their airway is maintaining and tolerating a Goodell airway. What investigations are you going to do? And what thoughts are going to be going through your head in terms of what other organisations you're going to need to involve? I'll give you 30 seconds to a minute to have a think about that.
So I guess having a quick think from my perspective, things that could cause someone to kind of pass out in the park. It could be a cardiac cause, something like a fit, a seizure. Given the nature of this talk that we're doing, it could be ingestion, deliberate ingestion of a toxic substance. So it could be an overdose. Similarly, it could be alcohol or accidental overdose of an illegal drug. What other things? We're also going to want to look at their blood glucose and think, could this be something like hypoglycemia? And they're all things I think that we can kind of then use to look at what investigations and history, assuming this person wakes up. And one of our viewers, Karen, is saying ECG, BP. Yeah, absolutely. Definitely things that we want to be getting.
So for this young lady, we did all those things. So they're great suggestions. We also did a urine tox screen when we managed to get a urine off this young lady. And that urine tox screen showed marijuana. We also recognised that she smelled of alcohol. And when she woke up, we had a very interesting conversation that went along the lines of, who were you with? And she was with young people older than her. So she was with some 17-year-olds that she knew. So she said she'd been out with friends. And then not necessarily on the immediate time you have that conversation, but you need to be thinking about, are those appropriate relationships? Is there any safeguarding concerns there? Is there any parenting safeguarding concerns in terms of either are the parents worried that they're hanging around with a bad crowd, for want of a better word, or lack of parental supervision that means they're going out and joining such groups? And often, sadly, it's a combination of those two factors.
Absolutely. Yeah, someone in the chat has highlighted exactly the same thing. So safeguarding team, why was the child on their own in the park at such a young age at that sort of time? And someone else has even pointed out, could they have been assaulted? Could there have been something else going on?
Great thoughts, guys. Great thoughts. Because let's be honest, I've seen cases that would fit with all of those things you've mentioned. Thankfully, this young lady had not been assaulted. She didn't have any bruises or injuries, other than the knock to her head where she'd conked over. And thankfully, that was fairly superficial. She admitted that she'd been drinking for most of the day with these other young people. But it wasn't until I said to her, so your urine toxicology has shown that there's some marijuana here. Did you smoke anything? And as long as you're fairly open, most young people, and some young people will clam up, but most young people are like, yeah, actually I did. And that then leads you into a nice conversation of saying something like, is that something regular that you do? Is this the first time you've had this kind of reaction? And that then leads you down the path of, is this marijuana on its own? Has someone doped her marijuana? So are you looking at a worse safeguarding issue than you thought? Because then you begin to think, do I need to involve the police as well as social care? And the great thing about safeguarding in paediatrics is often you'll have a three-way conversation anyway. So the police safeguarding unit will be on your kind of little MDT. I suppose at the moment, let's be honest, most of our MDTs are via Teams or Zoom or whatever platform that's secure that we're using. And the lovely safeguarding policeman will go, this family are not known, there's no role for us here. But in this case, they said, oh, actually, we have been worried that there's been some tainted marijuana happening in Huddersfield. Can you get us an extended tox screen? And the answer will be, I'll speak to the lab and ask. Because let's be honest, a young person who with alcohol and marijuana doesn't wake up after 12 hours, because it was 24 hours before this young person woke up, I gave her a shot of ceftriaxone in the end, just in case it was meningitis. And pulled off PCRs just in case it was meningitis. Because it is pretty rare to see a young person that's come in with, even with a fairly significant drug overdose of a recreational drug, that doesn't wake up until 24 hours post the event. So this was very much one of the cases that I'd scuttle back off to the consultant corridor and go, guys, this child's not waking up. I don't know why. I've sent off bloods for X, Y, and Z. And they're like, have you sent a urine tox? I'd be like, yes, I've sent a urine tox. Do I need to speak to tox base? And I did actually speak to tox base once we'd got the extended urine toxicology back, and said to them, look, have you come across any cases where marijuana has caused this level of problem? And then you find out, because tox base know so much more than you do, that actually there are some newer synthetic batches of marijuana being brought out that are much more concentrated and are much more dangerous and can cause significantly more side effects than their previous counterparts. And you'll be like, oh, I feel richer in knowledge, but no better in protecting this child. So is there any questions about that case? Fantastic. So let's move on to our final case for now, which is essentially a somatization or medical presentation. So I saw a young man of 12 that presented with recurrent vomiting and headache. So he came into my clinic, looked pale as a pale thing, as in white as a sheet. He was an anxious young man, but great interaction, pretty great insights. He acknowledged that he suffers with anxiety. And we had to discuss together an investigation and management plan. What do you think your investigation and management plan would be for this young man?
So you were saying he had some vomiting.
So recurrent vomiting, so daily morning vomiting.
Every morning.
Every morning, also every lunchtime.
Okay.
And
the first thing I would want is probably a good, accurate timescale diary. You know, is this happening on weekdays or days when certain activities perhaps are going to be happening at school or on the weekends? Sometimes PE, sports, drama club, whatever the young person's having a particular difficulty with, or you know, maybe going to either mum or dad if they're, you know, their parents are separated over the weekend. And again, it could be just weekends that they have this.
Those are all great thoughts. Once you've got to the bottom of that, is there any kind of red flags for medical conditions that you want to be ruling out from what I've told you?
So in our chat, we've had some suggestions to do UNEs, and someone said blood sugar as well. Absolutely. TFTs. Yeah, so I guess kind of, yeah, I think the blood sugar is definitely an important one. I think that's definitely a potentially kind of your red flag. Abdominal pain, could there be someone in
And so
TIA? I guess what they're getting at.
That this child was pale as a pale thing, as in, I have very rarely seen a child whiter than this young man. What else are you going to want to be doing? I'm hoping that your brains are whirring over and thinking, Helen, I'm going to be doing a full blood count and a blood film. Because I did. And that you might also want to check their ferritin level. And, dig down a little bit into whether they drink shed loads of milk. So he's the wrong age to be my typical patient with severe iron deficiency anemia. But let's be honest, I see it a lot. They tend to be the toddlers that have a diet of 90% milk and 5% food. And their parents think they're fussy eaters. And you say to them, have you tried giving them less milk so that they're not full all the time? Like, but they cry, and like, children do cry. You have to put up with that. You need to introduce food to them. It is good for them. It has minerals and vitamins and involves them not being iron deficiency anemic. So we did that, and his red cells were down a little bit, and he did need a little bit of iron. Sadly, that was not the thing that made him pink again. You'll be glad to know that he had a completely normal blood film and didn't have any hideous leukemia or things like that, which, let's be honest, I have sadly seen one case that presented not so dissimilar. They had leg pain, though, more than abdominal pain. You can occasionally see brain tumours presenting this way, sadly often the ones that have got Mets, because by the time it gets to the point where you're super pale, that is the anemia of chronic disease. And your red cells are usually in your boots by that point, and you're in need of transfusion and sometimes platelets and other useful, nice things that hematologists give you. And so there are lots of potential medical diagnoses here. I looked into gastritis and gave this young man some PPI, see if it helped with his vomiting. But actually what really helped was a hearty dose of propranolol. It helped with his migraines. It helped with his abdominal migraines, which were actually what was triggering the abdominal pain and the vomiting. When he had particularly bad episodes, we also gave him some ondansetron to help reduce the vomiting so that it wouldn't become a vicious cycle of being worried that he was going to vomit. So kind of vomiting happened anyway. And over a period of 2 years, he now is the pinkest child I look after. He now does sports. They now go on family holidays. They weren't going anywhere. Their quality of life was horrendous for the whole family because of this young man's challenges. And I also got him support via low-level CAMs. And the difference between the young man that looked at his feet, that was pale as a pale thing, that let his mum do 90% of the talking, and the young man that now tells me about his favourite football team, and we agree that I'll see him in a year just to make sure he's all right before discharging him, is beautiful. And that is why medicine is excellent. When you're getting it right, you get to see people much less often and get to talk about fun things more than you talk about their diagnosis. And that's what most of us are aiming for, essentially. The time when you can wave to your regular asthmatics and go, any admissions? Are you remembering to take your preventer inhaler? Have you had any oral steroids this year? How often are you using your blue inhaler? Let's do a quick peak flow. Let's have a quick listen to your chest. How's school going? And then you have a nice chat about their current recreational activities. That way you learn more about them. It makes the consultation so much more enjoyable for you as a practitioner. And also it makes it a much richer experience for that patient. Any questions about the kind of what I'm going to call generic somatization presentations?
Doesn't look like it. I think everyone's just quite happy to have the answer. I think it was quite a yeah, there were lots and lots of different suggestions, all very sensible ones. But yeah, I think people just wanted to know what it was in the end.
This young man could have been any of those medical conditions that many of you suggested. And that is why your surgical sieve will never be a problem and will always be an essential tool to you, regardless of how senior you become in medicine. But as I said before, the key thing is thinking of those key tests that are going to rule out those heavy hitters for you. So Essentially, this young man, I don't think I did LFTs on. I did TFTs, a celiac screen, a full blood count, and a film. Because his headaches were so bad, we also did an MRI. And headaches are one of those things where you have two options. And it's very much one that you need to discuss with the family and the young person, because you can either watchfully wait and not scan, or those that are really anxious or have a really significant family history of oncological problems, it is best to reassure them and reassure you that you just scan early, but then don't scan again, even if the headache changes, unless there's focal neurology associated. Or where you do a bit of a flex. And let's be honest, flex is where I often sit, where you say, look, I don't think we should scan today. However, I want you to keep a headache diary for me for the next 2 weeks. And if things change, I want you to phone my secretary, and then I will request that MRI scan if it's necessary. So then they're not waiting 3-4 months to see you again, because let's be honest, that is the average wait time. However much I'd love to see some of these patients in 2 weeks or a month or 2 months' time. I give my secretary as the open door for those patients to come back, because it's a 2-minute job for me to request the MRI on EPR, and a 2-minute job for me to write a sentence saying this child's headaches have not improved or got worse. Therefore, as discussed in the consultation, an MRI will be requested. And it just means that that level of trust between you and that family is just maintained. You are not accidentally, because let's be honest, none of us deliberately make patients wait for things. You're not accidentally making them wait twice as long for a test. And yet you're not ordering tests unnecessarily. It is a fine balance. We all get it wrong. Let's be honest, I get it wrong. With not infrequency, sadly, but I try and learn from those incidents and take them forward, so that the next time I see a similar case, I don't do the same. So, Q&A time. Is there any burning questions you wonderful people have about mental health in children that I might be able to answer? There are some things that, obviously, I'm not a CAMS paediatrician. I've seen lots of children with mental health difficulties, but if there is questions I can't answer, I do have an excellent friend who is a CAMS paediatrician, who I have at the end of text message, that I can always text your questions to and get you answers within the next couple of days.
Okay, no burning questions are coming in at the moment, but by all means, if anything does pop up over the next day or two, I will pass it on via email to yourself.
So, my key takeaways for you: what can you do as a junior doctor? You can listen. You cannot judge, because let's be honest, we do it all the time with our friends. We think, their new girlfriend's awful. And some of us may keep that to ourselves. Some of us are terrible humans and tell them. And if you're protecting your friend, fair game. But when it comes to your patients, don't judge them. Be open. Take any safeguarding concerns seriously, as we mentioned last week. You do not need to be their counsellor. So only offer constructive advice and activities. And that might be for distraction or as a way to move them forward. You are not a CAMS practitioner unless you become a CAMS practitioner. Please work within your limits as you would for anything else within medicine. The key thing you can do for that child is help them to take control of their own situation. Give them back some of the power so that they do not need to seek power in inappropriate coping mechanisms, such as self-harming, such as taking overdoses, such as developing an eating disorder. And be the signpost. That is also your biggest role. Signpost to useful resources. On which notes? Here's some of mine. There are wonderful things on practitioner health. There are wonderful things just on the internet in general. I literally Googled mental health in children, and this wonderful 10 ways parents can support their children build positive mental health habits came up. So, and funnily enough, none of it's rocket science. It's things like help them problem solve efficiently, talk to them, let them get some exercise and some sleep, feed them, encourage them to think positively about themselves, Praise them when they do well. Try and work together. If they are having a meltdown, give them cuddles, not shouting. Or if they need a minute, encourage them to breathe deeply. And encourage them. Number 10 is essentially what we said is the most useful thing you can do. Encourage them to develop autonomy. Because autonomy is the thing that is going to make the biggest difference in mental health conditions. With that in mind, we've got our useful resources on the right. Now, some of them I have looked at, some of them I have just taken from the top 10 tips of CAMs in various different regions. I like how some different CAMs use different ones. The ones I find the most helpful are at the top because I've either used them myself or because they are just wonderful services. So the SAM app was developed from somewhere down south. I want to say Bath, I might be wrong. It might be Bristol, somewhere that begins with a B, I think. But it's an app that you can easily get on your phone. It's free. All the content is free. And my favorite thing that it did is that you could explode your worries. So you could write down what was worrying you, be at school. Mine was clinic. Write down clinic and you press it and it explodes in front of you. Oh, it's visually beautiful. Exploding your worries is fantastic. Sadly, having looked on the SAM app recently, having not needed it for 2-3 years, you can't explode your worries anymore, or I couldn't find that easily. What you now do is you can float your worries away. You put them on a boat and send them off.
That's interesting. Have you seen Worry Monsters? The little stuffed toys with the zip.
I absolutely love Worry Monsters. I have given a Worry Monster to my 2 nieces and my nephew. And my nephew became a worried monster after Halloween because they went to a terrifying circus. Well done, my sister. He became worried that monsters would come out of the mirrors at him. And my sister and my brother-in-law were encouraging him that monsters aren't real. I think to an extent that's unhelpful because, of course, we all know that monsters are real. They just happen to be people. Not necessarily the thing of nightmares. So instead, I reminded Jean that they have a worry monster and that what Miles should do is write down his worries and feed them to his worry monster, and that therefore there are some good monsters out there that can take away his worries. And within 24 hours, he was sleeping again. Go, Auntie Hen Hen. The other things you can do on the SAM app are you can mindfully color. Oh, it's hilarious. And I think coloring is a wonderful thing. When I was anxious again, I found great calming in those very complicated coloring designs that are now deliberately designed for adults. Because there is something wonderful about neatness within lines, and you know that just plays up to my slight stationery related OCD tendencies. But they can be very helpful. But on the app, you get to pick a serene picture, whichever you find most serene. So things like beaches. There's a picture of bees. Clearly, some people find bees very serene. Or some like beautiful mountain ranges or a snowy landscape. And it makes it all misty for you, so it's all covered. And what you can gently do with your finger is gently uncover your wonderful picture of peace. I don't know if that significantly helps young people, but I found it an excellent distraction, if nothing else.
Interesting. I just wanted to highlight that someone has put a question in the chat. So they said that they are a PA student. They've come across this issue a couple times on placement, where essentially a child has had a social worker at school, bonded really well, seen really good improvement in their kind of behavior, mental health. They then moved to secondary school, lost contact with the previous social worker, been told there's a 6-month wait to get a new one, a lot of delays, and essentially they take a massive step back. So the question they've said is what kind of would be a good course of action apart from talking therapies, because again there was a very long wait in the cases that this person
Absolutely. as we said, the problems, as we said, our spider diagram with the problems with social care and the problems of CAMS wait lists is an absolute cracker. We all probably know from our own experiences of times when we felt not amazing for whatever reason, that what you don't need is someone saying, in 6 months' time, someone will talk to you. Because in 6 months, be it your friends, your family, yourself, you will probably be better. And at that point, it is useless. You need something to help on that day, which is why I've remembered the name of the app. Please write down Kooth, Kooth. That is at least the Yorkshire and the Humber system that young people can go on to and get immediate help. And by immediate help, I mean at least during the hours of 9 a.m. till 9 p.m, someone mans the chat so that someone can go on and kind of essentially MSN Messenger a trained CAMS professional to give them some immediate advice. It's not a program for CBT. It is not a kind of intense interaction, but it is enough to prevent them from self-harming or prevent a crisis. And what that wonderful practitioner can do is then direct them to helpful resources. So some of the other things I said on here, some of them are talking things like Childline and the Samaritans. Headspace is wonderful. I would highly recommend it, even if your head doesn't need any space. If you think your mental health is perfectly perfect, still download Headspace, because there are always going to be days when, for whatever reason, you've had a really busy day, you've had an awful resus case, even if you've managed it beautifully, and your head is whirring like a cyclone, and you've got another long day tomorrow, and essentially you're up till 2 a.m. like buzzing, going, oh, I can't quite get this case out of my head. Headspace have some beautiful mindful meditation. And, you know, I was very much one of those people that was like, mindfulness, what's that? And also meditation, that's for yogi bears. And actually it's beautiful. I played it to my friend who had a breakup. He was asleep within 2 minutes. I have never got to the end of a relaxation session in Headspace before I'm asleep. So if you have any issues with sleep, Headspace is brilliant. There is also some very specific focus things about depression, anxiety, other mental health difficulties, but I'd highly recommend it. It was the thing that once, it's funny that nobody talks about mental health until you're talking about it. It was the thing that once I started talking about my anxiety to my colleagues, I found out that about 50% of them were already using. One of the beautiful things it does is encourage 5 minutes of mindful meditation in your car when you get to work a day. If you are someone that's anxious or becomes anxious about clinic, and I really hope none of you ever do, but let's be honest, sadly, most of us at some point in our lives have a bout, however brief, of challenges with our mental health, and anything that can make that better just means you don't stay in that hole for as long. And essentially, it's thinking about the kind of weight of your body against your seat in the car, thinking about your breathing, just being really aware of where you are in the moment. It can be sometimes really challenging to be in the moment when you're a doctor and you've got 20 different things wanting you in 20 different directions. But I really encourage you to take even those 2-3 minutes a day for you to ground yourself, because we do a very difficult job and are in situations where we go from one crisis to another. And even if you're not going from one crisis to another, without intention, you take on the emotional baggage of the families you meet, even if you manage to put them away at the end of the day. And I know some fantastic colleagues who do that way better than I do. But you need for yourself a little toolkit of ways to manage that. And, for me, I play my rock music really loud. Or better still, nobody can be sad listening to the song DuckTales, which is the theme tune to a wonderful 80s cartoon. If you can be sad and listen to DuckTales, you're a stronger sad person than I am. Because even when I have had a fallout with my boyfriend and we have had a raging row, if I go in the car and put on DuckTales, I cannot help but smile. For you, it might be something different. For you, it might be your children. For you, it might be a dog. For you, it might be going to somewhere beautiful where you can see water running. I find surfing is a brilliant care for my worries, in that when you are out there with the waves, nothing else matters. Find what works for you is my top tip. because it will be different, and it will be different at different seasons of your life. But whatever it is, take that time, even when you feel you have no time, to be nice to yourself. And it is the thing that people told me over and over again when I was unwell, and still remind me when we're in the heart of winter and we're all chaotic now, is that we need to look after ourselves, we need to look after each other, and we need to be kinder to ourselves. Because I still find myself, even on my good days, going, oh, Helen, your inbox has about 20 letters in it. Why have you not read them yet? And I'll remind myself that I've already addressed all my email inbox. I've already done the whole ward round and it's only 10 a.m. and that I should probably give myself a break. And that by the end of the day, I'll have read those letters and responded to them, and that we're not Superman. Your local CAMS website or the local offer website from the CCG can be helpful. And then there are some brilliant things that I haven't tried, but are highly recommended by CAMS units up and down the country. So Worth It sounds amazing. It's I think it was set up by a school. It's essentially trying to encourage children that they are worthwhile. How awful that we have to encourage children that they're worthwhile. But if it's the only place that's doing it, well, please point them in that direction. WhatsApp, close to WhatsApp, but essentially dealing with that. Mind Shift, Mood Path, Mood Track diaries all work on a similar idea of kind of tracking what your mood is, or changing how you think about things. Because let's be honest, mental health doesn't go away. We all have mental health challenges at times in our lives. It's how we deal with it or think about that or process it that is different. And the way that I deal with the problems that still exist, that I have no control over when my patients turn up for clinic, even if they're 20 minutes late and I feel guilty and feel I have to see them anyway. That used to really upset me because I'm very organized and I like my clinic to run to time and get very upset if it doesn't run to time. Funnily enough, when you change your thinking and think, I'm never going to be able to control when they get here, I'm just going to have to see them when I see them. And if they're 20 minutes late for their appointment and their appointment's only 20 minutes long, I am fully within my right to say to them, I will reappoint you. Or I'm fully within my right to say, okay, you've got 5 minutes. We will go over the critical problem for today, and then I'll invite you back in a few months' time. And once you shift your thinking, suddenly you go from having molehill mountains to mountains that aren't even a molehill. Smiling Mind, I just love the name of. Haven't looked at it myself, but it sounds great. Calm, I have downloaded but have never tried. Mindful Powers sounds great. It essentially, from the app picture, looks like you're trying to encourage your mind to be a superhero, which I think is brilliant. And then even better for me, reminding children that they sometimes need to take the time for themselves. I just found this beautiful picture that just really encapsulates the encouragement of what can help cultivate good habits, that encouraging children and young people to do things that make them happy. And do you know what? That will, as we said, will be different for everyone. That might be going for a walk with their dog. You know, we've all heard stories of when a dog being introduced to the family of an autistic child has led a child start speaking when they never did before. Or it might be that child hates humans, as in they are quite a socially isolated young person. My ex-husband was quite a socially isolated person and much preferred the company of our reptiles than actual people. And actually giving him 10 minutes to hold the snakes was much better than trying to encourage him to go to the pub. So it is all about thinking about what that person is going to find beneficial for them and accepting that will be different for all of us. But that encouraging them to do that wonderful thing that makes them happy is going to put them in a positive track. So, in summary, children's mental health really matters. It impacts on every single element of the rest of their lives and on every single element of their care. It affects our children with chronic disease. What I didn't touch on, and what we could do a whole other lecture on, is about how children with chronic disease such as diabetes, celiac disease, asthma that's severe, children with additional needs and cerebral palsy, have a very interesting self-worth or worldview that is often affected by their mental health. And not having psychological resources or resources to be able to give these young people means that fundamentally you can be trying to manage their sugars with insulin all you like, but they will still have hypos or extreme highs because you haven't managed the fact that they don't want to inject in school because they're embarrassed. It comes into every area of your life, personally and within work, and it is well worth giving 5 minutes to have a little think about. Thank you very much for listening, everybody. I would really appreciate your feedback. Obviously, this is a new set of webinars. I am very keen to improve. If there's anything you want to know about that we didn't touch on, or if there's any of the format that you'd have preferred to be different, please do tell me. I will not take offense as long as it's constructive. Please do give us some feedback. We really, really appreciate it. And I really hope you've enjoyed the session. If there are any questions, please do send them in.
Okay, thank you very much. That was really informative. Lots of interesting different things there. Very much enjoyed the cases. Yeah, absolutely do get on, give us some feedback. We genuinely read it all and we take it into account when we make the next webinar. Just while we've got this up on the screen, just want to touch on a couple of other things. So firstly, we're going to be taking a break next week because there is a finance webinar from Mind the Bleep going on at the same time. So we're going to have a week off and then return the week after. So keep your eye out on Facebook, keep an eye on your emails, and we will let you know about the session that's coming in 2 weeks' time. I also just want to mention our new sponsor as well, which I think is CPD Me, which is a website that provides you with lots and lots of different webinars that count towards your portfolios, whether that is for GMC or the nursing equivalent, so the NMC, I think. But through Mind the Bleep, using the QR code that we put up earlier in the webinar, you can get 50% off, which is £8 a full year's access to as many webinars as you can get your hands on. So please, by all means, do check that out. Do give us some feedback, and thank you very much for attending. So